this is me. I've got a crawler and I've got a caption on Facebook. Don't have that facility on Instagram, but anyway, never mind. I'm a professional. I will rise above it. Stiano's my name. Plastic surgery's the game. Any questions about plastic surgery or lockdown 2.0, then please feel free to ask away. Although, to be honest with you, I think we've got quite a lot of lockdown 2.0 covered with these questions, because I've got about 5 or 6 questions and about 4 or 5 of them are lockdown 2.0 related. But anyway, what we've got, I've got to try not to overlap them because they're all pretty similar. But anyway, let's drag it out and see how we get on. In the light of the second lockdown, will my GA surgery still be going ahead? I feel slightly, I've got my phone in the way, haven't I? Slightly sort of bad. Oh, my book. I'll get my book in the shot. Oh, no, slightly bad because, there you go, there's a book there. Slightly bad because I haven't got any, oh God. I meant to get an email out. I meant to get an email out onto my mailing list about the about all this, and I haven't, and I feel bad about it. But I will email out my list in at some point about all this lockdown 2.0 issues. But the specific question: will GA surgery still be going ahead? GA surgery has been significantly affected by coronavirus. Full stop. So even once lockdown 1.0 finished, we were struggling to do GA surgery, although have just started doing GA surgery, and I have done a few cases, and I've done some today, in fact. And so we are just starting, but nevertheless, it is strictly, it's quite limited the amount of GA surgery we can do in general, not because there's any safety issues, but mainly because of the accessibility of the hospitals, because the private hospitals where I would normally do the GA work have been taken over by the NHS, and that is going to be, they've been saying since lockdown 1.0 that will be the case till Christmas, and now that it looks like the cases are getting worse, quite frankly, it might be that might be extended. I don't know, they haven't told me that'll be extended, but that is an issue. So GA cases are affected by the coronavirus in general, but in terms of the lockdown specifically, everything, I mean, I'm going to answer all 5 questions in one go, but basically we are not going to close this time. Last time we closed, we're not going to close this time. We are remaining open. It's a medical facility, and medical facilities and work is being encouraged to carry on going as long as you can do it safely. We're quite lucky in the clinic because it's quite small. Throughput of patients we have 1 patient at a time, and so therefore we're quite good on distancing. We've got, obviously all the PPE, and we will screen you before you come, both with a questionnaire and when you arrive. And so we have got quite good procedures in place to carry on working. So we are going to carry on working, and so the clinic, I'm going to answer the other questions. So the clinic is open, but and GA cases are going to be still being done, albeit in a limited fashion. And we're looking at other places to do GA cases, but elective work is still going on. Elective work meaning planned work, which during the first lockdown, elective work was cancelled, and it was only urgent work. And now elective work is going on during this lockdown. So that is a slight difference from a medical standpoint, that we are doing procedures. So GA surgery is still going on during second lockdown. Don't panic. And the other thing I've said to people who I've done surgery on, not to worry about follow-up and aftercare. That will not be affected, because if you have any issues, if you have any problems after your surgery, then that is a medical issue, and you are perfectly reasonable for you to come to clinic, and we'll see you, and we'll, if you need a dressing or if you need any advice about your wound, don't think you can't come out. You must still come. I mean, contact us. We're doing everything we can by non-contact, that we can do by non-contact, but obviously procedures and surgery, quite tricky to do non-contact. But I'm sure the day will come, but that leads me on to my second question, which is, will minor ops at the clinic be cancelled due to lockdown? And I do feel bad. If this helps you, I do feel bad, because we had quite a lot of emails of people saying, I'm going to have my procedure on Thursday, and can I have it on Wednesday instead because of the lockdown, and and what have you. Tracy's in the house. Looking forward to seeing you on Thursday too, Tracy. Hope you're well. Hope you put your feet up. So what was the question? Minor ops. Yes, minor ops will not be cancelled. Sorry, will not be cancelled. Now, there's two things with the coronavirus and with the COVID. There's from our side and from your side. So from our side, they're not be cancelled. Things aren't going to be cancelled. But and minor ops are not cancelled. We will be doing minor ops during the lockdown. But if you don't feel comfortable, and if you don't want to come out because of everything, fine, that's perfectly reasonable, and we can definitely postpone it, and there'll be no penalty with that. So we can definitely postpone your surgery if you feel that you don't want to come. And I would completely understand that, and there would be no problem with that with your minor op or with your GA procedure. If you want to postpone your procedure, whatever type of procedure it is, then you are perfectly at liberty to do that with no sort of penalty, and that you can either postpone it to another date, or you can have a refund, no problem. But from our side of things at the moment, and it is a moving thing, isn't it? At the moment, clinics and medical facilities are staying open and seeing and treating patients. So that is the state of play. Are you still... You see, maybe we should have started off with consultations, then moved on to minor ops, and then moved on to GA. But anyway, we'll do it in reverse order. Sign of a professional, can take the questions as they come. Are you still doing consultations at the clinic? Yes. Now, as I say, we're trying to do as much as we can virtually. So we are encouraging people to do it virtually. To be honest with you, from the clinic's point of view, nothing has changed for lockdown 2.0, because post lockdown 1.0, we were pretty stringent with what we did for people when they came to clinic. Therefore, we are okay during this second lockdown, because we have measures in place to distance ourselves and to screen patients, and to use PPE. So we got measures in place which will allow us to continue doing consultations. Having said that, and this was the case before, we are encouraging people to do virtual consultations when they can. We'll do it like this. We have a chat like this with a virtual thing, or just on the phone. We can do phone consultations. We can do video consultations. But if you feel that you want to come to clinic, and certainly if you've got something to show me or one of the doctors, scar or something, and we're checking up post-op from your surgery, and you want to come to clinic, or you're pre-op and you're thinking of having surgery, you want to try on the sizes, and you want to go over everything in person, that is also fine, and those consultations are going ahead at the clinic. And same about the minor ops. If you don't feel comfortable coming, totally understand it, and you want to postpone it, totally understand it. You can postpone it, no problem at all. Will there be more complications and risks with procedures with COVID-19? Should I postpone my surgery? Good question. Thank you for that question. Jury is... Well, is the jury out? What I'll say is that there is some evidence to suggest that if you have surgery and you go on to develop a COVID-19 infection, you will have a worse outcome than if you hadn't had surgery. So there is an argument to say you should postpone your surgery. Having said that, when you look at the work they did to come up with that data, the patients who were getting the bad outcomes were quite ill, if you like. ASA probably means nothing to you, isn't it? It's an anesthetic grading, meaning how ill you are, and they're sort of ASA 2 or 3, which means they've got other problems, they've got other medical problems, and they're having longer operations. So and to be honest with you, most of the surgery that I do is the patients don't often have other medical problems, and I don't do them that long. In fact, we are curtailing the length of the surgery because of this. So we're curtailing it to 4 hours because of this, because they're saying if you do longer operations in ill people and they then develop COVID, there is an argument that either they may get a worse outcome than if they hadn't had surgery. So we are, as I say, we're already doing measures to reduce the length of time of the surgery. So we're not doing operations that take more than 4 hours. And we would tend not to do surgery on people who have got other comorbidities. And so certainly if you're ill, if you've got other medical problems, or if you've got medical problems, and if you are considering a longer operation, then there is some suggestion that you might have a worse outcome if you develop COVID-19 following surgery than if you had developed it and you hadn't had surgery. A question is, can you extrapolate that to people who aren't ill or haven't got comorbidities and having shorter operations? And the evidence isn't there really for that. So, but the bottom line is, so there isn't evidence to say that you should postpone your surgery. And if there was evidence, we wouldn't do the surgery, to be quite frank. But the bottom line is, if you want to postpone your surgery because this is an unknown thing, this is only been around for a relatively short period of time, so we don't really know what the effects are. If you want to postpone your surgery, that's absolutely fine, and there's no problem with that. We just personally, I have found it to be extremely busy, and I think a lot of people want to have surgery because they're naturally at home. It's a good time to recuperate, and I totally understand that. And as I say, we've got measures in place to perform the surgery safely, both in terms of your safety, in terms of you developing the COVID, but also, me and the staff, our safety, because obviously we don't want to get it. It doesn't want to go either way. So, but we got pretty good things in place. Shirl-E Bradley. That's annoying. Shirl, did someone else get Shirley Bradley and you had to put a dash there? Type 1 diabetes is a comorbidity, Shirley. So you have an ASA grade of 1, 2, 3. So 1, there might be 4. I think 4 is like, moribund, really ill. 3 is like loads of problems. 1 is nothing. And so, 1 is nothing. So you'd be 2. I think that would make you 2. An ASA 2. So yes, Shirley, type 1 diabetes is a comorbidity. So it's not a significant comorbidity. Well, depends on which way you look at it, but it does increase your risk of infection, and it's something that we would have to factor into account. The people in that study who had the worst outcome with COVID had more than just type 1 diabetes. They had more comorbidities, and they were having longer operations. But it does sort of put you up. You're at a higher risk level, I guess, than someone who hasn't got type 1 diabetes. No, I'm a nurse. Can't put identify by name. Oh, so Shirley's not your name. Oh, right. Okay. All right. Okay. So, Yeah, so type 1 diabetes would be, but having said that, Shirley, having, oh, well, if that's not your name, Cheryl, we'll call you Cheryl. If you're having surgery, you can still have surgery. It's fine. And if I had type 1 diabetes, I'd probably be more worried about the risks of infection and getting everything healed up. That's probably more of a risk than the COVID related risks. And so therefore you have to make sure your diabetes is maximized before you have the surgery. And the things we'll do, we'll put you first on the list. You know this probably if you're a nurse. Put you first on the list and make sure your sugars are controlled. And then I presume you want to probably get you back on your insulin after post-op. Yeah. So yeah, have I done that one? Oh yeah. So yeah, Shirley. So if you think you have surgery, should you postpone surgery? It's up to you. But I don't think the significance are. Oh, it is my name. It's just not as easy to find if I just. Okay. All right. I like it, Shirley. I should be J-J, J exclamation J, hashtag J, hashtag ask JJ. No, I shouldn't be that. Oh God, where are we? So will I be able to change my follow-up consultation to a phone call instead? Yeah, I mean, I think, to be honest with you, are these really questions, or is these just the people in the clinic? Is this just Megan and Vicky making these questions up? I don't know. Anyway, I'll answer them anyway. Yes, you will, Megan or Vicky, or if maybe someone did ask this question. Yes, you can, and you can do that anyway. And there's a lot to be said for it, isn't there? We did quite. I was really busy over the lockdown doing all these virtual consultations on the phone and the video calls. You're saving on petrol. You're saving on time. You don't have to drive to the clinic. And obviously, if you've got no problems, if you're just having a follow-up and you've got no problems, and you just say, look, yeah, we'll do a phone one. And if I've already seen you in the clinic and it's just a sort of follow-up to go over what we discussed, then a phone one is really good, or a video one. Similarly, for initial consultations, a video one is good because I can do a screen share. I can share my screen and show you photos, and we can talk about a lot of stuff on the video chat, which would reduce the length of time you're at the clinic. And so, yes, you should, and we are encouraging people to do that, to have phone/video consultations when possible, to reduce the contact. Donna Lewis Quinn, is that you, Donna? Hi, sorry I missed you last week. I didn't know you were on Facebook, Donna. Heard it went well, and you were very well behaved. See you next time. Thank you, Donna. Yes, Donna, it was amazing. Donna, it was amazing. And can we have more, please? I'll have to get Sally to get on the blower to your people so we can get some more dates in. Donna, I'm going to get my people to wrap with your people, and we'll see what we can do. Kim and family on the Instagram. Hi, what's best, please? Drains/no drains after a tummy tuck, please. How do you answer that one? The problem with this stuff, Kim, the problem with all this stuff, this plastic surgery stuff, and all sorts of particularly plastic surgery, to be honest with you, a lot of plastic surgery, it's like someone saying, what's the best implant? Is it best to have drains or not to have drains? Well, the fact of the matter is, Kim, some people use drains and some people don't use drains. So the people who use drains think it's best to use drains, and the people who don't use drains think it's best to not use drains. So there's no best. There's good and bad, and we've all got our views on it. I do use drains. I still do use drains. And I use drains because there's a space with the tummy tuck, and I want that space to close down. And so I use a drain, which is a suction drain. It's under negative pressure to help close that space down. Now, I do also do quilting to help close that space down. And to be honest with you, the drainage is not that huge. When they first came out, this no drain thing, when that first came out, it was people using glue. and using fibrin glue, injecting the glue in the space to stick it down. I never really embraced that. I have done it, but I never really embraced it personally because I was worried about shear, and also you have to be very quick closing the wound because the wound is you've got to stitch it up and keep the glue in place quickly. So you have to use something like that. You have to use these barbed sutures and things like this because you haven't got much time to close the wound, because if the wound's sort of gaping open and you're just slowly closing it, there'll be shear. I don't know if that makes sense, but so I didn't like that. I didn't like having to quickly close the wound, and I didn't think, and I was worried about shear, and I was worried about seroma, which is my worry with the glue. Now, as I say, I am quilting, and quilting I think might have mileage as to, because I know some people are quilting and not using drains. There might be some mileage there, and sometimes you got to sort of take a bit of the leap. I took the leap with the breast reductions, so I'm using drains a lot less with breast reductions. We used to use drains routinely. Used to use drains routinely for breast augmentation. Stopped that a long time ago, but I'm still using it for tummy tuck. I think the movement is away from drains. I'll be honest with you. The patients don't like drains, but I think they're doing a good job in tummy tucks, so I use them. But you'll find another surgeon who's very good who'll say, well, I don't use drains for these reasons, and if they get good results and I get good results, then just Kim, my advice is choose your surgeon. People, it's like the breast implants. People, which one should I have, under, over, this and that? I'm like, choose your surgeon. Don't worry too much about the breast implants, the actual breast implant you have. Don't worry too much about whether you have a drain or not. The thing that's going to give you a good result or a bad result is going to be your surgeon, much more than whether they use a drain or not. So that's my advice on that one. Melanin, 0161 Melanin, catchy name. Do you do BBL? Now I'm going to say that's the Brazilian butt lift, and no, I don't, Melanin. I'm afraid I don't do buttocks, and we haven't really embraced it in this country. Buttocks, I've got to be honest. I think some people have. Because there was a bit of an outcry. God, was it last year? I think it was last year. Because there was a few fatalities with Brazilian butt lift overseas, in terms of the fat injections into the buttocks, and so the BARPS, the Plastic Surgery Association, said we shouldn't be doing it, and there was a bit of an outcry. So people must have been. I was like, yeah, fine, I don't do it anyway, so it didn't really, didn't affect me. But I think there was some people in this country who were doing it, so I think they were a bit disappointed in that, because they felt that it can be done safely and there's certain measures you can take to do it safely, but we're not really full on. And as far as I'm aware, that is still in place, that edict that we shouldn't really be doing Brazilian butt lift, or at least not with fat grafting, because of the risks associated with it. But it's not really something I've ever done, Melanin, I'm afraid. So sorry, I can't help with that. Kim, I want to come to you, but you said I'm far away. I said you're far away, did I? Well, go closer to home, Kim. Where are you? Where's far away? Did I recommend someone then close to you? Trying to think, where are you? Anyway, yeah, it's always good. It's always good to, mind you, I'm doing surgery far away these days, so can't really practice what I preach, can I? But I've got to do surgery where I can. So it's this crazy world we're in. Dear, oh dear. My private journey. I had drains with you, JJ. They weren't a bother. Look at that. I don't even know who my private journey is, but my private journey had drains with me. Well, my private journey, did you? There you go. Well, that's good to hear, my private. Do you mind if I call you my private? People don't like them, though, my private. I think the feeling of them coming out is not very nice. But thanks for saying that. And I don't think they're sort of that bad. But some people. Oh, 5 days ago. Oh, right. Oh, so I can work out who my private journey is then. Right. Okay. Oh, well, there you go. I'm glad to hear that they weren't bad coming out. You obviously had the expert nurses dealing with them. Good job that I didn't take them out, because I think they wanted me to take them out, didn't they? And I recoiled in horror when they suggested that. Oh, that's good. That's good to know. So Kimmer family, Cardiff, and yes, you recommended someone, Hugh, Hiew, Mr. Hugh, and also Anthony McQuillan is in Newport, I believe. So lovely people. Cardiff's not too far, but yeah, there are good people down in Wales. I mean, anyone in Swansea. Swansea's a great unit. Yes, it was weird. I think it's the feeling when they come out, isn't it? Yeah, I think no one really likes that. Let's be honest with ourselves. No one likes it. I acknowledge that that's not a nice thing. I do acknowledge that, but I do think they do a good job. Fionn Hughes. Hi there. Do you do lollipops? Lollipopos? Lollipos. Lollipos lift with reduced scarring and mini tummy tuck. I am micropigmentationist. Wow. And terrified of the scarring I usually see. I didn't like it. Oh, sorry. That's Tracy. Oh, Tracy didn't like it. Right. We got a balance of opinion there. Okay. So my private journey thought it was all right. Bit weird. Tracy didn't like it. Yeah. Sorry about that, Tracy. Yeah. Theon. So, yes, I do both of those things, Fionn. Lollipos lift with reduced scarring and mini tummy tuck. So basically, the thing here, Fionn, nobody wants scarring. Even if you're not a micropigmentation specialist, no one wants scarring. If you say to people, do you want a big long scar on your tummy and a scar around the nipple and down and also in the anchor, or do you want a little scar on your tummy and just a lollipop scar, or even just a circumareolar scar, just a circle around the nipple, because you can do a lift that way, a Benelli or circumareolar lift. It's all right. If you say just that, they'll say, well, I'll have less scarring, please. I'll have the shorter scar. I'll have a mini tummy tuck scar, and I'll have a, circumareolar or a lollipop scar, because I don't want more scarring. No one wants more scarring, and that's fine. You don't have to have more scarring. You can have less scarring. But the thing you've got to remember is that less scarring means less skin's removed, means less of a result. Because let's face it, let's be honest with ourselves, this surgery is basically skin removal surgery. It's skin tightening, it's body contouring surgery, and it's tightening the skin. That's why you need a breast lift. That's why you need a tummy tuck. You've got too much skin. The skin's been stretched either by pregnancy or weight loss, typically, and then the stretching force has gone and the skin hasn't recoiled. So there's too much skin. So you need to remove skin. The more skin you remove, the more scarring you get. The tighter and the more contoured your body is, but the more scarring. So yes, yes, absolutely. Lollipop lift's great. Mini tummy tuck's great. The other thing I've got to be honest about the lollipop lift, in my hands, Fionn, I hope I'm saying it right there, Fionn, in my hands, and it's I find often with a lollipop, I think the lollipop really comes in if you're doing a lift with implants, because the implants are taking up some of the slack, and then you can adjust the amount of lift you do. But as a pure lift, I often find with a lollipop, at the bottom of the lollipop, you get a dog ear, because if you can get your head around this, I don't want to get too technical, but a lollipop lift is taking skin out from a side-to-side direction only. So it's a scar around the nipple and then straight down. So it's only taking skin out in a side-to-side direction. It's not taking any skin out in an up and down direction. So when you take it up in an up-down direction as well, then that's when you get the T, the anchor scar. So when you're just doing it in a side-to-side direction, if you look at a lateral view of the breast, if you look at how much skin there's often too much skin in an up-down direction as well as a side-to-side. So the side-to-side will narrow the breast, and the horizontal scar will take it in a vertical direction, in a sort of up-down direction. And so I often will put a little. So you often get a dog ear. You often get a dog ear at the bottom of the vertical scar, and so I will often just at the end convert to a short T, I'll just do a short T. So not quite as long as a full T, not like a breast reduction, big long T, but a short T. And basically, so I will usually, unless I'm doing a lift with implants, sometimes with a lifted implants, I'll just do a pure lollipop. But for a pure lift and certainly for a reduction, I'll do a short T. And the length of the T will be dictated by the amount of skin you have to remove. The more skin you have to remove, the longer the T. So if it's, a breast reduction, there's a lot of skin, you might get a, full on anchor. If there's less skin, less T, less horizontal portion. But yeah, that's an issue, Fionn, with in terms of scarring versus result. Similarly with a mini tummy tuck, mini tummy tuck, great, no scar around the belly button. Scar if you've got a cesarean, it's just a bit longer than your cesarean scar, but it just really contours the skin above the pubic area. If you've got a cesarean scar and got a bit of an overhang above the cesarean scar, it's really good for fixing that. That's what it's really good for. It doesn't really contour the whole abdomen, and it certainly doesn't do anything above the belly button, because you're not making a scar on the belly button. So the belly button's a sort of anchored point. So you sometimes the belly button gets pulled down a bit, looks a bit pulled down, usually settles, but it just removes some skin below the belly button, and it doesn't remove any or contour anything above the belly button. And you certainly can't do anything with the muscles in terms of repairing the rectus muscles with a mini tummy tuck. I say you certainly can't. You sort of can, but there's issues around it. So it's not a part of it. It's not a routine part of a mini tummy tuck doing anything to the muscles. So it's just for that bulge above the belly button, really. Oh, gold. I didn't like it. Rosie, you got a chat coming up, I believe. Will drains come out before the patient is discharged, or will they go home with them in? Rosie, in my practice, Rosie, I do not send people home with the drains. I know that some people do. So just for those people out there who are maybe not, there's very few people out there who maybe not be treated by me, perish the thought, but if there are anybody out there, no, in my practice, I do not let anyone go home with the drains personally. The drains always come out before you go home, but there are some people out there that do let people go home with the drains. As I say, usually it's tummy tucks and big breast reductions where I'm still using drains, and they're usually in one night. So yeah, they go, and you might be able to go home that night. The next day. They try and not to keep them in for more than one, maybe 2 nights in terms of the drains. Did you say previously you'd written a new book? Yes, I did, Kim. I did. Thanks for bringing that up, Kim. I haven't got it published. I'm basically on the last chapter of proofreading, which, full disclosure, I was in the last lockdown. Do you know what the problem is, Kim? I had a routine. And I used to do it every Thursday. I used to do some stuff in the morning. I do some calls in the morning, and then I go to the local coffee shop down the road with my laptop, and I'd do my book. That's how I wrote my book. Every Thursday, I'd go down there and I'd go to the coffee shop. It's just down the road, and do my book. But now with all this lockdown thing, you can't go to the coffee shop and do your book, can you? That you're in and out as quickly as you like. They don't encourage that. So I haven't been down there. And if you haven't got that routine, I don't know if you can relate, Kim. If you haven't got that routine, it just doesn't get done. So I'm neglecting it. I feel bad, but I am neglecting my new book because it's finished. I've written it. It's completely written. I've got to get the artwork on it and get it published. If I set my mind to it, I could have it, a week and it'll be done. But thanks for reminding me, Kim. It's called Mind Your Own Business, How to Turn Your Private Practice into a Business Rather Than Just a Job. And it's for doctors. It's for consultants who are in private practice who want to give a better service to their patients. So it's not really for you guys. I mean, you can have a copy if you want, but it's not really it's not really your thing. Lindsay, how do you know if you need muscle repair or not? You know what, Lindsay? A lot of plastic surgery is dictated by the patient. And so if you don't think that you need it, then you probably don't need it. Is the first one. It's a bit like, someone comes to clinic and says, right, what can you do for me, sort of thing. And it's like, well, what's the problem? Because if nothing's a problem, then I'm not going to do anything for you. But if something's a problem, let's talk about it and see if I can do something for you. I'm not going to just look at someone and say, oh God, you need this, this, and this. So a lot of plastic surgery is guided by the patient. But in specific answer to your question, Lindsay, because I appreciate that's perhaps not a very helpful answer. The muscle repair, we do call it muscle repair. You're quite right calling it muscle repair, but you're not really repairing the muscle. It's called muscle repair, but you're not really repairing the muscle. You're just sort of bringing them closer together. It's the rectus abdominis, the six-pack muscles. Although it looks like the six-pack muscles are going across, they don't. They actually go up and down. The muscle fibers go straight up and down. And there's things called tendinous intersections, which go across ways on those muscles, which give it the appearance of the six-pack or the one-pack or the three-pack or the people five-pack. There's all different, depending on how many tendinous intersections you got. So there's all different types of shapes of abdomens. So those two muscles, as I said, they go straight down. They can be splayed apart a bit. So with things that make you need a tummy tuck, which is basically pregnancy and weight loss, or at least putting on weight, those muscles can get stretched apart. And you get what's called divarification of the recti muscles or diastasis of the recti muscles. And the way you assess that is you tense the rectus. So you would either lift your head and shoulders up, lie flat on your back, lift your head and shoulders up off the bed and feel above your belly button to feel if there's a gap. You'll feel those two rectus muscles tighten and you're feeling for a gap between them. Similarly, you could lie flat on a bed and do a straight leg raise, both legs straight up on the bed. That will tense your recti muscles. And you can just feel above your belly button for a bulge. So that's how you tell if you need them to be brought back together or not. And you can sometimes see it. You can see the bulge when you lift your head up or lift your legs up. Gastric says, hi Gastric. Celie, you seriously need to write a book about all the procedures you do. Yeah, I've thought about it, Kim. I thought about it. I don't know if I've disclosed this to you. I think I have disclosed this on a previous Facebook Live. Theatre Blues. What do you think of that title? Is that a bit depressing? I thought that Theatre Blues. All the titles. I don't know why I've got to have all the titles being sort of like double meaning. Like Never Accept a Lift from Strangers. The problem is, I think people don't know what. I think the problem with that title of that book is people don't know. People look at it and think Never Accept a Lift from Strangers. It's some kind of horror or not horror, private detective thing or something like that. They don't realize what it's about. Same with Mind Your Own Business. I'm not sure if they know what that's about. But anyway, yeah, Theatre Blues, because the scrubs we wear are called blues. Do people know that? Is that common knowledge? Yeah. Anyway, I mean, that's Kim. I need to get down the coffee shop if I'm going to write that one. So thank you. Look at that, Kim. What you mean this? You mean this one, Kim? Never accept a lift. Oh, is that what you mean there? So you see that? Does that say it's about how to choose a breast surgeon? Maybe not. Maybe I should have called it How to Choose a Breast Surgeon. Anyway, hey ho, is what it is. Right. Thank you. Welcome, Lindsay. You are welcome. How are we getting on with our COVID 2.0 questions? Yeah. Will I be able to change? Right. Last question, guys. Get your questions in because this guy right here is going to go and put his feet up in a minute. All right. But if you've got a question, get them in. Gastric's got a question. Good on you, Gastric. Would I be able to have a mastopexy augmentation and a full abdominoplasty in the same procedure slot? Well, normally, yes. Absolutely fine. Known as a mummy makeover, tummy surgery, breast surgery. Absolutely fine to do it in on the same slot, and they and that is perfectly acceptable. But as I said earlier, the problem at the moment is we are limited in the time of the surgery due to this potential problem that you might have a worse outcome from COVID if you were to develop COVID after surgery, if you have a lung operation. I think we need, I hope that, there's more work done on it to see whether that is the case or not, because it's certainly not a definite whether that's the case or not. But at the moment, because that has been suggested, we are limited to doing surgery for 4 hours. So that would affect your ability to have this sort of surgery. So in terms of mummy makeover surgery, being breast and abdominal surgery, you could potentially do some mummy makeover surgery in 4 hours, but it would depend on what combination you had, and it also depend on your body type. Some people, if you're a bigger person, a tummy tuck is going to take longer than on a smaller person. I know what you're going to say. You want to discount. Well, unfortunately, we don't discount it for smaller people and put the prices up for bigger people. But fact of the matter is, some tummy tucks will take longer than other tummy tucks. So it depends on your body habitus, and it also depends on the combinations. And I've got to be honest, a full tummy tuck and a mastopexy augmentation, they're both quite big ops, to be fair. And I think that would be a bit of a struggle to do in 4 hours. Not impossible. If you are quite slim, it might be possible. But that's going to be top end. That's going to be top end of your 4 hours, that is. So I'm not sure if that's a goer or not. Gastric. I was talking to another surgeon's wife, and we agreed we should write a book. We'll do it. Gastric. Absolutely. Well, don't take my title, gastric. I shouldn't have said my title, should I? Oh no, I've lost it. I have to think of another one. Don't you take my title, gastric. All right. No, you can if you want. You can have it, because I'll probably never write Theatre Blues. You can have it. We can both write one. We can both write Theatre Blues. I can do Theatre Blues too. Yeah, go for it. Yeah, you write a book. Absolutely. You should. You should. Published author, It's got a bit of a to law. Too late. Never too late. Never too late, gastric. That's the thing. If you put your mind to it, once the coffee shop's open, you get down to the coffee shop every Thursday, a couple of hours. Get done. Well, first of all, you write it all out. And then, actually, what I did for one of them was the first one. I dictated a lot of it. And then got it transcribed, and then just went through it all. So that was the first one. I dictated a lot of it. I think the second one I typed more because I was doing it at the cafe. But yeah, that's quite a good way to get quite a lot of work. Stuff on paper is by dictating it. Alan Tracy Hicken. I'm 52, BMI 29. Would I be okay for a TT, Mr. and Lipo? Mr. You've been on the forums, Alan. They're trying to catch me out with their Mr. abbreviation before. Muscle repair, isn't it? Yeah, not going to get caught out this time. Mr. Butt. Yeah. Would I be okay for a tummy tuck? Yes, you would, Alan. Well, I don't know. Depends if you've got too much skin on your abdomen, I guess, which I'm assuming. I'll take that as a given that you're asking the question. But, for males, it's usually a weight loss issue. So I don't know if you've lost weight. It'd be unusual for a male to need a tummy tuck who hasn't lost weight. But if you have tummy tuck, if you have excess skin on your abdomen and you have separation of your recti muscles, then absolutely fine. In terms of the BMI, there's two things. One's the absolute number, and 29 is fine, because anything below 30 is deemed to be sort of safer than above 30. It's not written in stone, but 30 is the sort of cutoff that we have. But the other thing I would say to you, Alan, is, are you happy with your weight? And is your weight stable? Those are the two questions, really, because if your weight isn't stable and you're not happy with your weight and you want to lose weight, I would always say to you, lose weight first, because if you lose weight after, first of all, you're going to get better. Your complications are less, the lower weight. But if you lose weight after surgery, then you could have some redundant skin there, which could have been made tighter if you had lost weight first. So yeah, I would say, are you comfortable with your weight? Is it stable? And if you've got a significant excess skin in your lower abdomen, absolutely, you don't see why not, Alan. But as I say, it's hard to say just based on that. But I don't know if you think you might not be okay. I don't know what part of that. I mean, 52 is fine, and BMI 29 is fine. So yeah, I don't know if you thought that one of those things would maybe make you not okay, but you're good to go on that basis, Alan. It would just be clinically whether you'd be appropriate. Rosie, what's up? Will a breast augmentation and full tummy tuck be within the 4-hour limit? A breast augmentation and full tummy tuck. Again, Rosie, depends on who. And so on you, maybe, but on, yeah, it depends on who, because it depends on the size of the tummy tuck. Really, breast augmentation is always going to be about an hour. But yeah, I think that would be within the window. So it's just the augmentation with a lift adds a bit of time to it. So just a straight up augmentation would be there. Yeah. Naomi T. Ellis, can you do breast implant / tummy tuck via local / twilight sedation? Naomi, you're asking there, aren't you? You are pushing the envelope, Naomi. You are pushing the envelope, girlfriend. Right. Can you and would you? Can you? Yeah, I reckon you can. Would you? Nah, I don't think I would. I don't think I would, Naomi. We're doing more and more of these breast augmentations, breast reductions, capsulectomy, things like that. Yes, local installation, fine. Next step up from that, tummy tuck. I've done one tummy tuck under local installation. It was quite a while ago, to be honest with you, and it was great. It was fine, but tummy tuck is pushing it. But it can be done. It can be done. Breast implants. So breast implants can be done. Tummy tuck can be done. Breast implants and tummy tuck. I mean, I guess it could be done. I guess it could be done. I'd probably, it's top end for me, that, Naomi. I'd be like, I don't know, Naomi. I mean, if there's a compelling reason that you really don't want a GA, what we would probably do is talk to the anaesthetist and say, look, what do you think? I mean, anaesthetists are really, the ones that we work with are really good. And it's almost like a GA, really, when you're having a local station. You are pretty sedated. It's not like you're awake. So I reckon it is doable, Naomi, but it'd be one of those ones where I'd be chatting to the anaesthetist and say, what do you reckon? And if you're a sort of what's the word, engaged or keen, that helps if your patient's on board. Oh, Abby Rigby's in the house. Oh, what's happened here? Sorry. We was going to call it sexy tips for scrimpers. Gastric, what are you on about? You were going to call your book Sexy Tips for Scrimpers. Sorry, I thought you were going to do a book about plastic surgery. I was talking to another surgeon's wife and we agreed we should write a book. We was going to call it Sexy Tips for Scrimpers. Right, so that's a different sort of book there, Gastric. I think you're in a different section of the library than I am. Different genre. Yeah. Blimey. Naomi, sorry, I have a huge fear of being put to sleep. Yes, well, in that case, Naomi, and that's why I did that, the tummy tuck years ago, because that patient had a huge fear of being put to sleep, and she was very motivated, and it went really well, and she was really happy, and it was good. But it is it is top end of the things. But to be honest, at the moment, I'm not doing tummy tucks under local installation. I'm doing them under GA. I feel like I've got to move on to that. I think we will move on to it, Naomi. I think we will move on to it. But yeah, you'd be at the forefront. But why? On paper, I think it could be done, and it would need a discussion between ourselves and the anaesthetist. And if you did it somewhere where you could do a GA, then you could always convert to GA if it's uncomfortable. That would be the other thing. So on that note, any other questions? I think I'm out. I'm out with my coronavirus lockdown 2.0 questions. I've done that one, haven't I? Yeah, I'm out. 3rd of November. Can you believe that? It's madness. So, right. Well, if you have any questions, please let me know and I will answer them, because I'm going to be right here next week. Lockdown 2.0 ain't going to stop this guy. Okay. He's going to be here next week answering your questions and your questions about anything lockdown related, plastic surgery related, local anesthetic and sedation related, you name it, I'll answer it. So please. Oh, Kim's in at the last minute. Come on, Kim, what you got? One thing I was wondering, but not sure if it's a stupid question. In your last book, you mentioned about checking to make sure your surgeon is properly qualified. But what about anaesthetists? Very good question, Kim. Thank you for that question. That is a good question. The problem and the reason I wrote the book about plastic surgery and plastic surgery training and making sure your surgeon's qualified is because we have a pretty much a unique problem with plastic surgery. It's like if you go and have your hip replaced, or if you go and have your cataracts done, you don't really have to check that your surgeon is a fully trained orthopedic surgeon or a fully trained ophthalmic surgeon, because basically it's only ophthalmic surgeons and orthopedic surgeons. Ophthalmic surgeons do cataracts, orthopedic surgeons do hip replacements, cardiac surgeons do heart valve replacements, neurosurgeons do brain tumor removal. Most realms of surgery, they don't have competition. There's not another type of surgeon that decides I'm going to take brain tumors out. I'm a plastic surgeon, I do brain tumor removals, or I'm going to do hip replacements. That just doesn't happen. Similarly with anaesthetists, there's no real sort of could there be? I guess there could be, but most surgeons will use fully trained anaesthetists who usually work in the NHS. So it's not so much of a thing that there's anaesthetists out there giving anesthetics who aren't trained. That's not really a problem in this country. Whereas people out there doing plastic surgery who aren't trained is pretty huge. There's a lot of people who aren't trained or either haven't finished their training, or some even haven't even started training, haven't done any training, or maybe trained in something else. As I say, they may be trained in general surgery or ENT surgery or A&E or some other surgical specialty, or not even a surgical specialty. Might be a GP or dermatologist or whatever. They might be trained in something else, and they're doing plastic surgery things. Now, sometimes they'll be within their remit, like rhinoplasty, for instance, nose jobs. ENT surgeons, perfectly reasonable for ENT surgeons to be doing nose jobs, and ears, prominent ears. Eye surgeons will perfectly reasonable be doing blepharoplasties. So sometimes other surgeons do sort of plastic surgery procedures, and that's fine. And I talk about that in the book, but it's when the ENT surgeon does the breast augmentation, or when the eye surgeon does the rhinoplasty, or whatever, that's the problem, when the surgeon's not trained in that field starts doing stuff. And breast surgery is a big one, to be honest with you, because breast surgery is quite a popular surgery. And the other problem we've got is that people will often search for a surgeon online. You wouldn't tend to search for a general surgeon or a brain surgeon or an orthopedic surgeon or whatever online. You'd usually go through your GP. By and large, people go through their GP if they're having their brain tumor removed or their, hip replaced or whatever. About plastic surgery, people tend to seek help online, and therefore people can put up a website and say, I'm a brain surgeon, even though they're a plastic surgeon, and I'll take your brain tumor out. Come and we get it done this month, and we'll give you a discount, half price, buy one get one free, and all this sort of stuff. That doesn't happen for anaesthetists, so you don't have to worry so much about you. So if you find your fully trained plastic surgeon, they're unlikely to be using a non-fully trained anaesthetist. I think most fully trained plastic surgeons will use fully trained anaesthetists who they've worked with usually in the NHS, and the anaesthetists usually have NHS contracts, have had an NHS contract. Certainly all the anaesthetists I have ever worked with have had an NHS contract. Some have left the NHS, like myself. I've left the NHS, but I used to be a full-time permanent consultant in plastic surgery in the NHS. So great question, Kim. And in answer to that, no, you don't have to worry too much about your anaesthetist. If you get your proper plastic surgeon, you'll be all right. Thank you for Kim. I'm up for it. I'm hanging. I'm waiting for a late question. I'm all over it. So thank you for that, Kim. Keep up the good work, and I will look forward to seeing you and everyone else right here, 7 p.m. Tuesday night. Have a good evening, and see you next week. I'm going to check out of here.